This is terrific. And by the way, this is every single slide is a question in exams of boards of cardiology, medicine, radiation, each and every one of those things. Those thresholds, the way to reduce radiation seems good, but when you try to do it in the room, you have to be cognizant of it. And when you try to answer the question, you need to know all these little things and tricks as well as the basic guidelines. That's why I don't have any questions on radiation safety, because you get them all right now, right after his talk, and then you're gonna forget by the next time. So let me connect my system, and I'm gonna give you some Q&A about the interventional cardiology concepts. Okay, well, all good and playing. Let's do some Q&A. And the way it goes is going to read the question, and then there are going to be 4 answers. We're going to read the answers, and then we're going to vote. All of you are going to vote by raising the hand for each option. And then we're going to go into the slide for the answer, and then we'll proceed like that. It's all about the cases anyhow. So I spared the sample question because I think the system is pretty good. We usually have the sample when we have these little clickers. So let's go over the patient who undergoes stress test and is found to have moderate ischemia in the RCA territory, okay, has some risk factors. Because of moderate symptoms, class 2, perhaps 3, or medical therapy, a coronary angiogram is performed, and the angiogram shows a hazy 50% stenosis in the mid-RCA. What will be the next step about this patient who is undergoing an outpatient elective catheterization? Okay, number 1 is do nothing. The stress test was probably a false positive. And B, consider stenting the lesion because a 50% stenosis is expected to be ischemia causing. And C, consider performing an FFR or consider performing an intravascular ultrasound. Okay, let's go. Who goes with A, do nothing? Not that many. Who goes with B, consider stenting the lesion? Only a couple. Who goes with C, FFR? The majority. And who goes with D? IVAS. Okay, good job. In the guidelines, because that's what we're examining here, the decision for an intermediate lesion between 50 and 70%, whether to perform or not to perform, lies with a physiologic assessment, which is the FFR and the IFR for the most part, or the analogs like QFR, etc. So using a physiologic assessment of this lesion. There's one study published just a few months ago that indicates that in the cases where they're low with a high FFR and the IVAS or OCT particularly would be positive for a very unstable plaque, there may be some benefit to stent those specific plaques, but that's an initial study and clearly hasn't made it to the guidelines. So the correct answer is clearly about the indication of the procedure to strengthen it with a physiological assessment, FFR or IFR. So the FFR comes up and has a value of 0.80. That's the FFR. We did the FFR. So let's go. Option A is the value of the FFR is non-significant, and therefore you decide not to put a stent. And B, the value is significant, and stenting it will prevent a future MI in this patient compared to medical therapy. And C, the value is significant, and stenting will prolong longevity of this patient compared to medical therapy. Or option D, the value is significant, and the stenting it will decrease the patient's chances of a repeat urgent revascularization compared to medical therapy. So who goes with A? The value is non-significant and forget about it. Nobody. B is significant and is going to prevent future MI. Not much activity. How about prolonging longevity? And how about decreasing chances for urgent revascularization? All right, quite a few. Then we have about maybe a 30% did not answer anything. The correct answer is, as the majority indicated, D, the FFR, the cutoff, is 0.80 or less. So 0.80 is a positive FFR value. So that's number one. Number two, in the FAME study, it indicated that it's a reduced MACE if you follow a FFR-guided PCI versus medical therapy in similar things, but mostly due to decreased urgent TVR, target vessel revascularization. The study, unfortunately, or for whatever reason, was stopped early due to a tremendous decrease in urgent TVR and MACE, so we didn't have enough power to assess anything further about MI or death, longevity that is, so we don't know what's happening there. All right. So this patient, continue with the same patient, presents 5 years later with recurrent angina, class 3 on optimal medical therapy. A stress test again shows ischemia in the RCA territory, or this RCA territory again. There is concern that the previous placed stent has reoccluded and angiography is performed. The stent is patent, but there is about 90% lesion of the large OM1 branch is found. What could be your next step? Do nothing. The stress test did not show ischemia in the OM territory is the number one answer. B, stent the lesion because the patient is symptomatic on maximal medical therapy. And the C is performing FFR, and the D is performing intravascular ultrasound. Where are we going with that? Who goes with A? Who goes with B, stent the lesion, when symptomatic? And C, FFR. Who wants FFR? How about IVUS? All right, that was a good answer. The patient does come with a significant class 3 symptoms and highly stenotic. We don't need to do FFR when the lesion is 90%. Let's go now to a different patient. All right, 62-year-old male with history of hypertension, hyperlipidemia, type 2 diabetes, quite a few risk factors, and has occasional dyspnea when he runs the stairs, runs up the stairs at work, but generally denies other symptoms. Echo has normal systolic function without significant valve disease, 12 EKG, unremarkable, normal sinus rhythm 55 beats per minute. The medical therapy consists of diltiazem, aspirin, and atorvastatin. The patient's cardiologist is worried that the symptoms are an angina equivalent and adds ranolazine. A month later, the patient follows up and has similar symptoms. The cardiologist performs a stress test that shows moderate anterior and inferior ischemia. And here comes, I went to the next version. There you go. Which of the following is correct? Regardless of the anatomy, it will probably be inappropriate to stent this patient. Therefore, a beta blocker should be added to the medical therapy before considering the angiography. And B, the patient is on maximal medical therapy for angina. C, according to non-invasive testing, the patient has a 1 to 3% annual mortality, or both A and C are correct statements. Let's give you back the body of the question for a couple of seconds. And let's vote now. A, who goes with A? Regardless of anatomy, is inappropriate to stent. Who goes with A? B, the patient is on maximal medical therapy. A couple of people. Who is C? About the mortality. Here with D, A and C. Well, several people. Well, interesting. Well, the simplest statement is the patient is on diltiazem and ranolazine. That's 2 agents, and that's on maximal medical therapy. The beta blocker, not so advisable because the heart rate already 55. So, and anyhow, the patient is on maximal medical therapy with class 3 angina, so that would be indicated procedure, appropriate procedure. The patient is referred for the cardiac catheterization, and the coronary angiogram demonstrates 70% discrete proximal LAD. The circ artery branches has maldiffused disease. The right coronary artery has discrete 80% proximal lesion. Because of the high-risk stress test, the patient is evaluated for revascularization. Which one is the following? A, patients should be referred for PCI because the syntax score is low. And B, the patient should be referred for CABG. C, the FREEDOM trial only included patients with 3 vessel disease. And D, the results of the FREEDOM trial appears is relevant only to patients with a high syntax score. Why do we go about that? Who goes with A? Who goes with B? Who goes with C? And who goes with D? Many people don't know this much about that. You escape to you, the patient is diabetic, has multi-vessel disease, and should be referred for bypass. The freedom trial included patients with 3 and 2 vessel disease. The majority was 3 vessel disease, so that would be the first line of discussion with these patients. So be very, very careful with these results, particularly the freedom trial results were applicable regardless of the syntax score. So, all right, let's go now to another patient now, had a little trouble with a diabetic patient. Let's go to a 68-year-old male with history of hypertension, hyperlipidemia, undergoing angiography for evaluation of angina and a positive stress test. Angiogram has obstructive lesions of the LAD, circ, and RCA. Syntax score is 32. Which of the following statements are true? The patient will likely enjoy freedom for revascularization 1 year after CABG than if the patient had PCI. The patient will not derive mortality benefit 5 years after CABG than if patient underwent PCI. At 5 years, the patient will more likely to benefit from CABG than a patient with a similar syntax score but with significant left main disease. And D, all of these statements are correct. So who goes with A? Who goes with B? Who goes with C? Who goes with D? Excellent. We kept going up. All right, all the statements are correct. This patient, the left main, seemed to have a little bit better results with a PCI than otherwise. Interestingly, why? Because so much of the syntax score is really in the left main. So it's really less lesions, let's say, fewer lesions. So let's go a few questions about shock. Which coronary distribution is most associated with cardiogenic shock? Who says anterior? Who says inferior? Who says lateral? And who says posterior? And you're correct, the anterior is mostly related with cardiogenic shock. All of the following are true regarding hemodynamic support, except which one? All are true, except which one? We're looking for the false statement. In patients with shock, there is no evidence that routine use of balloon pump reduces 30-day mortality. In patients with shock, the tandem heart and impeller CP provide superior support as compared to balloon pump and have significant mortality data. In patients undergoing high-risk PCI, impeller 2.5 compared to balloon pump allows more complete vascularization but does not reduce the incidence of irreversible events. And number 4, the hemodynamic support device is recommended for patients with shock after STEMI who do not quickly stabilize with pharmacological therapy. Who goes with answer number 1, A, as a false statement? Who goes 2? Who goes 3? And who goes with 4? Very good. So the wrong statement is that there's not a lot of mortality data with these support devices. We do use them because they have hemodynamic data, and we believe we offer hemodynamic support. Lately, first study came positive just a couple of months ago, mostly in the longer term, interestingly, not in the shorter term with the impeller. So let's go back to the classic shock trial, which is examined in all and each and every, I would say, exam you participate within cardiology. Early revascularization therapy, number 1. Early revascularization therapy in shock was associated with 50% reduction in mortality in all patients. Early revascularization was associated with a 50% reduction in mortality in the younger and older patients, but smaller numbers of older patients prevented this from being significant. Early revascularization was associated with a 20% reduction in mortality in all the patients and a smaller, non-significant reduction in the elderly patients, or early vascularization was associated with 20% reduction in mortality in all patients, but higher mortality in the elderly patients. All right, you need to know really the results of the shock trial. It was published about maybe 2 decades ago, still very, very, very important trial, derives the guidelines. So who goes with question number 1 as main finding? Answer number 1. Who goes answer number 2? Answer number 3? Answer number 4. There you go. Early vascularization was associated with a 20% reduction in mortality in all patients with a higher mortality. Elderly patients, that's why when the patients are over 75 years of age, it's acceptable to follow an initial medical stabilization strategy, perhaps a balloon pump or whatever other way you want, rather than putting them right away to surgery or PCI, most PCI these days. All right, question 11. In patients treated with revascularization therapy now with shock. So they have shock and we take them to revascularization. Mortality rates was similar in patients treated with PCI or CABG in the shock trial, or mortality rates were lower in patients with diabetes who were treated with CABG. Mortality rates were higher in patients treated with PCI or were lower in patients treated with PCI. So who goes with number one? Who goes with number two? Who knows number three? Who knows number four? We have a distribution. All right. The answer is very similar. Of course, the study did not randomize PCI versus CABG, so it was just a selection of patients. The outcomes were sort of about the same. So that's why a very small number of patients went into the bypass, of course. Yeah. And the final question is, a 64-year-old man notes a sharp chest pain that lasts for seconds and not related to exertion. In fact, says he walks every day for exercise. Physical exam is unremarkable except for slight overweight. EKG unremarkable. Does not recall having been treated or evaluated for any heart condition. Which of the following would be appropriate first step in the evaluation of this patient? Does not need evaluation because patient is low risk. Cardiac catheterization, lipid profile, or echocardiogram? All right, who goes with A? Who goes with B? Who goes with C? And who goes with D? You're doing great. You answered pretty much every question right. We need to brush up a little bit on the shock trial results. Great, great responses. Congratulations, and keep remembering this subject when you take your internal medicine, cardiology, or interventional boards. Good luck.